Okay, so next we have Dr. Dayananda Sharma from Apollo Proton Cancer Center. He's a physicist by training, but he is now involved in developing cancer therapy pipelines for individualized patients at the cancer center. And he will be talking about how he's using AI in developing treatment plans for radiation. Thank you.
Good afternoon, and thank you all, and thank you to Professor Ravi and Himanshu for this opportunity. And this talk is going to be more about the introduction of this particular discipline and how we can utilize the AI in each and every steps of this particular discipline. So this is Apollo Proton Cancer Centers, where I work as a medical physicist, and of course by training I am a physicist, but I'm specialized more onto the use of radiation in the treatment of cancer, and that's also the reason why the topic is on the use of cancer radiation for the treatment of cancers. So just to introduce, I think cancer can be managed with three modalities, and the radiation therapy is an integral component above surgery and the medical oncology. And the goal for each modality is the same. We want to irradiate. Sorry to interrupt. Sure. You want to share? Sorry. So the goal for this modality is the same, to eradicate or to remove the tumor and while protecting the critical organ. So this is the goal for every modality, whether it's a surgery, medical oncology, or radiation oncology. So in case of radiations, how we are going to achieve is by using radiation. And so you can see over here that this is the tumor wherein we want to deliver a curable dose while protecting the critical organ, which is right at the center of the tumor. So this is the goal. And in order to achieve this particular goal, I think the technology has evolved in the last many years, especially in the last 3 decades, and these are the different radiation delivery machines which is available commercially, and with these, I think we are able to deliver more and more conformal dose to the tumor while sparing that particular critical organ. But in most of those, I think the technology which I have just shown you, I think all of them use high energy X-rays, and because of the inherent characteristic of the X-rays, what it happens is that while treating the tumor, it also irradiates a lots of normal tissues before it reaches to the tumor, as well as after delivering the dose to the tumor, it comes out and it hits the organ lying behind that. So the side effects are likely to be slightly more in case of those patients who are treated with photon radiation therapy. So there is a recent development wherein I think instead of using a uncharged X-rays, you can also utilize the potential depth dose characteristic of the charged particle, which is called, in this case, it is proton. And if you see the depth dose characteristic of proton, then I think it doesn't come out after delivering the radiation to the tumor. At the same time, I think the dose delivered before it reaches to the tumor is very less. So because of this inherent characteristic of this particular radiation, so we can reduce the dose to all these critical organ. So this is the same patient the plan by using a very I think high-end or the sophisticated technology using X-rays, and this is the same one with the proton, and you can see the difference that you are able to reduce the dose to all this surrounding organ, and that this is going to lead to the reduction in the side effect, and which will improve the clinical outcome in terms of quality of life. So this is the first proton therapy facilities in Southeast Asia and the Middle East, which was installed at Apollo Proton Cancer Center, which is located in Taramani. So wherein I think we use a isochronous cyclotron to accelerate the proton, and the protons of energy ranging from 70 MeV to 230 MeV are delivered in 3 treatment room, okay, which is shown over here. And this proton can be delivered by using a technique called pencil beam scanning technique, just like my laser pointer here. So I can imagine that the laser light what you are seeing on the screen is the proton beam, so I can just move my reeds to positions the proton at any point in this particular slide. So that's how we treat our patients using the proton beam. And so any form of radiation therapy, whether it's a X-ray based radiation therapy or proton beam radiation therapy, I think it's a process. So I think, of course, all the patients are treated in the OPD basis, and it's a process, and we have to follow this particular process. And the first process starts with the diagnosis and the evaluations, and wherein we use a lots of multimodality imaging, as well as we use we use clinical as well as histopathological data to diagnose and evaluate. And once it is once it is evaluated, then I think we took a final decision in the multidisciplinary tumor board, and a particular protocol has been designed or assigned to treat to treat this particular disease with the radiation therapy. And this is the first step of our radiation therapy process, wherein we have to prepare a immobilization device so that the patient don't move during the time of treatment, and their positions are reproduced. And after that, we take a series of imaging modalities, whether it could be X-ray or MRI, PET-CT, depending upon the clinical indications. And all those data are transferred to a dedicated computer called a treatment planning systems, wherein we have multimodality image fusion registration algorithms, and we can extract all the useful information from each of the imaging modalities, and to really exploit the 4 Ps, what Mr. Ashok has mentioned in his inaugural talk. And in using these modalities, I think the radiation oncologists identify the tumor as well as the critical organ. And from there, I think we reconstruct a 3-dimensional database. And we create a treatment planning system based on the technique what you are going to adopt for that particular patient. So for this instance, so in this case, it is a proton beam radiation therapy, wherein we have used the intensity modulated proton therapy technique. And we analyze the data. Then after that, I think we ensure that whatever we have simulated in the computer is going to deliver to the patient using a method called the patient-specific quality assurance. Then once it is satisfactory, then I think you take the patients for the treatment. And again, once you take the patient on the machine, then I think you have to ensure that the patient is exactly in the same position as that of the simulation. And that is done by using another onboard imaging modality called the Quantum CT. And if any deviation is there that are corrected in 6 dimensions, then after that, I think the radiation is delivered. And post-radiation therapy also, you have to regularly follow up the patients. And as a part of the follow-up protocols, we take multiple imaging modalities in the form of PET-CT or MRI to evaluate the response of the tumor. And of course, at the same time, I think we also use the clinical indications like the skin toxicities during the time of treatment as a part of the short-term toxicity profile. So if you see in this entire work process, then you see that I think each and every process is very labor intensive, and it takes a lot of time. And especially, for example, I think from the simulation to the first fractions of the treatment, I think it takes approximately 1 to 3 working days compared to considering the complexity of the clinical cases and also the technique what we are going to employ for that particular patient. But in case of proton beam, it takes still longer time, like 3 to 5 working days to complete this particular process. And it also involves multidisciplinary team like radiation oncologists, medical physicists, and radiation therapy technologists who is really going to treat the patients on the machine, and of course other supporting cares also. And it requires a multi-level human interactions between the human and the machines, right? I think it's in the every steps, I think we have to interact with the machines, and it demands a high degree of precision, and any kind of weak link in this particular process is going to lead into the compromise on the quality of treatment what we deliver to our patients. So we need to execute each and every process very efficiently, effectively, and at the same time very precisely. But at the same time, because of the involvement of the human interactions, then there are interobserver variations, I think, reported, say, for example, for the critical organ delineation. So in this example, I think this is a multi-institutional studies wherein the various institutes has delineated the same critical organ differently. You can see the variations in the brainstem delineation, variation in the spinal cord, variation in the brainstem, as well as the oral cavities. Similarly, even for the same clinical indications like, say, a pancreatic tumor, the interobserver variation in delineating the target volume has been reported from different centers, and this is going to lead to a compromise on your treatment outcome, and we have to restrict or we have to address these issues, and this can be done by following the standard protocol which is developed through the consensus guideline. And even after following those protocols also, the errors are still there, and that can be still minimized by following those protocols, but the errors are still there. So the next step was, again, the treatment planning process, and wherein I think, so you can see over here, we have all those images, I think, wherein we have delineated the target volume and the critical organ. And here, the physicist, I think, say, for instance, me, is going to interact with the machine. And here, I am going to provide many parameters where to start the to start the optimization process. And so because of the involvement of this, the human interventions over here, then the outcome of the treatment plan is going to be different based on the complexity of the cases because of the expertise of the persons who is going to actually create this treatment plan. And as a result of that, you can see a large variation in the outcome of the treatment plan for the same patients for the same technique. So this need to be addressed, and this can be addressed using our AI. So this slide tells everything. So this slide is, I think, probably the slides which suffice why AI is required in radiation therapy process. So in each and every steps which I have discussed in the past, so lots of data are being generated, and all these data are digital data in the form of image, in the form of the electronics data. So all these data can be utilized, I think, to create a model, and so that I think we can improve the quality of the treatment, we can standardize the treatment process, and we also can ensure more safety, more accuracy, and at the same time, I think we can reduce the time of radiotherapy delivery significantly. So if you see in this particular slide, so you can see, I think you can imagine, each and every step, I think the AI have a role to play. So AI can be used to do the contouring, what the radiation oncologist was doing, and the AI can be used to create a treatment plan, which the physicist was doing. And so AI also can be used to diagnose the patients and stage the patient appropriately. So these are the various applications of AI explicitly in radiation therapy process. And so some of the examples, right? I think we have been using all these tools for the last so many years, although it was a little bit of not exactly AI, but we have been using it for the last many years. Say, for example, in this case, wherein I think we use these edge defining algorithms, edge detection algorithms, wherein you can delineate the lung without any, I think, manual intervention. So you can just set the threshold of the Hounsfield unit, and the algorithms will automatically detect the edge interface between the lung and the bone, and with that, I think you can automatically delineate these structures, which otherwise would take a lot of time. So similarly, say when the entire skeleton can be delineated automatically by setting a threshold of the CT number, as well as by using the edge defining algorithms. And the limitations of this particular method is that I think they don't work in the soft tissue medium. Say, for example, in soft tissue, suppose in case of head and neck cancer, if I want to delineate the nodes and the primary tumor, then I think this algorithm doesn't work. So this model-based algorithm has been introduced, and in the Atlas-based algorithms, wherein I think the model has been created using the data set which has been created or which has been generated by expert manual contouring, and of course, I think you require around 20 to 25 data set to create this kind of model. And with that, I think you can use a deformable image registration algorithms, and that can be translated into your patient in order to map the target into your patient. But the limitation of this particular technique is, again, I think they are highly dependent on image similarities, and so a single model or the single atlas is not sufficient to deal with your spectrums of patients. So you need to generate multiple atlas, and atlas which has been created from the Western country patient database is not, again, applicable to our patient data set. So these are some of the limitations of this particular algorithms, and whenever we evaluate the goodness of that particular model, we always use this kind of parameters, like we use dice similarity index, then sometimes we use the centroid movement. So we use different types of, I think, evaluation tool to evaluate whether the algorithm is doing the right thing or not. And recently, I think people started using this deep learning algorithm, and especially the UNet. And so these are the example of two clinical indications wherein UNet has been used to delineate the target and the non-target structures. Okay, and of course, there are several studies wherein I think people talk about how to compare the different the tools which is available for the target volume delineations, and this is one of them. And here it shows that the ML-based algorithms outperform what do you call it, model-based, atlas-based algorithms. And especially in the, again, treatment planning, so this is what we are doing right now. So this can be done using the AI-based algorithm. So here, I think we can use a knowledge-based planning approach wherein this initial parameters, which I was controlling and I was playing around. So this parameter can be picked up from a trained model, and that can be used as an initial parameter to start your optimization. And this will reduce, or this will provide you a treatment quality plan which is similar to that created by an expert physicist. So there are different approaches to do this. And again, when it comes to, again, the patient-specific QA, to ensure that whatever the plan we have simulated on the computer is delivered on the machine, so we perform this, which is called the patient-specific QA, wherein I think we have to actually deliver the plan which is created on the computer onto the treatment machine, and compare the measured dose versus the planned dose, and using various analysis tool. And especially in proton therapy, these are very time consuming. Again, I think this is part of the studies which we have published very recently. Here we have seen that, I think, I think it takes more than, I think, 50 minutes to 1 hour, 20 minutes, depending upon the clinical indication. So in order to reduce the time, we have developed another approach, I think, which is more of a mathematical based approach, and we have written down the algorithms, and we have tested this approach which has been published, and we found that, I think, this approach is very fast compared to the previous method. But the limitations what we are facing over here right now is that, I think, the analysis take relatively longer period of time. So we are looking for, I think, another approach wherein we can use the ML algorithms to do this particular task. And these are the various algorithms which has been used in other studies, I think, which is into the photon radiation therapy. So in those areas wherein, I think, the pass percentage is less, we also can analyze why the particular QA plan is failed, and that can be done by using all these feature selection methods. And we are also looking for something called a Logfilebased quality assurance, wherein, I think, we can, so whenever the plan is delivered on the machine, so the machine generates a log file, so we can extract the log file from the machines, and that can be utilized to reconstruct the dose onto the patients, and that can be compared with the actually computed dose distribution. So this is another approach which we are looking at. And so another area of AI is that, I think, so we can predict the outcome of the tumor. So right now, I think, so this is a plan which is created by from the helical tomotherapy, and this is from the proton therapy, and you can see the difference between these two plans. So this is the extra dose which we were delivering using the high energy X-ray based technique. And using these dosimetric informations, we can calculate the normal tissue complication probability to various critical organs. So these are the normal tissue complication probabilities. And we see that there was a significant reduction of the normal tissue complication probability for various function when we use proton beam radiation therapy. I think we have recently published this particular paper also. And during the treatment also, I think we do see some side effect which is unexpected. And so in this example, I think we show some skin reactions to those patients who was treated with proton beam therapy. So we use, again, the AI-based method, I think, to predict the skin toxicity. So we use the database from 44 patients, and we extracted the so-called skin surface histogram. And using this dose surface histogram, say, we evaluate the parameters which are more significant for the production of skin toxicity. And using those data, again, I think we use unsupervised, I think, K-mean clustering method to cluster those patients, groups of patients who has got different grades of skin toxicities. And so we found this, that, I think, so around 40% of the patients was having grade. So this was, again, in agreement with the clinical finding, although we have not presented in this particular topic. And whatever the informations we extract from this particular studies was incorporated prospectively in our planning process. And with that, I think we are able to reduce the dose to the skin. And you can see over here that, I think, that is also reflected as a clinical outcome. So now this patient doesn't have any skin reaction compared to those patients who used to see the grade 2 to, at some patients, grade 3 skin toxicities. This also we have, I think, contributed. Yeah. And another area is, I think, during the time of radiation therapy, I think there is a lots of changes in the patient anatomy because of various reasons, and we need to adapt. And so whatever the plan we have created before the first treatment doesn't hold true in the subsequent fraction. So we need to adapt our treatment plan based on the changes in the patient anatomy. So for that, I think we also need to create multiple image set, I think, which is called a virtual database. I think so we can create the virtual CT, you can from the cone beam CT, we can create virtual CT from the MRI. So we can create all this database using AI and ML, and these are the challenges what we are facing at the moment. And so I think in conclusion, I think AI can play a major role in radiation therapy work process, but I think we are yet to get the consensus guideline for validation, acceptance testing, commissioning, and the maintenance of AI-based tool. And so we have to identify the clinical data and clinical and the data challenges. And we also have to analyze the risks associated with the use of AI-based algorithms in our work practice. Thank you very much. So this is the team at APCC. I think I was a little fast.
Okay, thank you, Dayananda. Any questions for the doctor?
Thank you very much, Professor. It was quite informative. I had two questions. One is about one of the slides what you have shown, that's on toxicity modeling.
Right.
So is it for the toxicity modeling what you have shown, is it specific to conventional radiotherapy or stereotactic radiotherapy? Because stereotactic radiotherapy, in my knowledge, reduces the collateral damage a lot because the radiation is divided from multiple angles, and from each side, the radiation that is entering the body will be pretty much limited and within tolerance limits. So when compared to conventional radiotherapy, that offers a lot more advantage.
I think I'm not sure whether I understood your questions correctly or not. Can I take it offline in the interest of the time?
Sure.
Thank you very much.
Yes, thank you.
Dr. Dayananda, please. So, Professor Geeta will present the moment.
Thank you very much.
Yeah.
Thank you very much. Very interesting.